This is Michael Robinson from the University of Cincinnati. This presentation accompanies Chapter 33, Brain Retraction, from the 8th edition of Humans and Wind Neurological Surgery. The objectives of this presentation are to understand principles of retractor-based surgery, to understand the pathophysiologic mechanisms of retractor injury, to review methods used to detect retraction injury intraoperatively, to review historical brain retraction methods, to understand modern brain retraction techniques, and finally, to appreciate the desired goal of moving toward less retraction and ultimately retractorless surgery. The basic principles of retractor-based surgery. 1. To gently create and maintain a safe corridor to surgical targets. 2. Visualize structures that are deep and usually unseen within the brain. 3. Protect vital structures from injury by keeping them away from the surgical corridors of instrument transit. And 4. Separate the tissue interfaces such that normal and abnormal tissue can be identified. Patient factors related to retractor-based surgery. Positioning. In general, the exposed and operative surface of the skull should be parallel to the floor or the ceiling whenever possible. For example, when dissecting toward the ICA bifurcation for an aneurysm, positioning the malar eminence toward the highest point of the field allows the frontal and temporal lobes to fall from the floor of the anterior and middle fossa. Maximizing bone removal minimizes retraction. Arachnoid dissection and opening of subarachnoid cisterns reduces the need for external retractors. Adjuvant techniques to surgical exposure. Manipulation of CSF is another method to lessen the amount of acquired retraction or retraction pressure. For example, this can be accomplished with intravenous mannitol or via CSF diversion with the lumbar subarachnoid drain or external ventricular drain. Technical aspects of retractor-based surgery. During initial retractor placement, visualization of the entire course of the intracranial retractor is ideal. If the surgeon is working under the microscope, their attention can be focused on the retractor tip, making it easy to ignore the cortical or venous structures out of their view, which are at risk of injury. We recommend placing retractors before the microscope is introduced. If retractors then need to be advanced or manipulated once working under the microscope, ideally one of the two retractor blades should be slightly moved while the other remains fixed, and then alternating that process as needed, in essence, walking the retractors one at a time to the target area. Technical aspects of retractor-based surgery. Current retractor systems. Most follow the basic premise of securing a frame around the patient's head, which serves as a basis from which a retractor system is built. For example, the Buddy Halo retractor system, shown later. Earlier systems mounted the retractors to soft tissue or directly to the skull. This could interfere with the surgeon's hands and provided less secure attachments. The profile should be minimized to prevent the surgeon's hands from encountering the retractors. The incidence of retraction injury. A rough estimate of retraction injury can be obtained from literature on aneurysm surgery, as the extra-peel surgical dissection should not confound intracerebral hematoma or edema postoperatively. In a large review of neurosurgical operations, 29% of brain tumor patients suffered intracerebral hematoma, whereas only 8% of aneurysm patients did. Other studies have suggested at least 60% of these hemorrhages were attributed to retraction. Radiographic studies have shown about 22% incidence of ischemic changes in the vicinity of retractors. Retraction injury can be estimated to occur in approximately 10% of skull-based tumor operations and 5% of aneurysm operations. Pathophysiology of retraction injury. It is known that irreversible cell damage results after approximately 5 minutes without cerebral circulation. Rosnan showed that increasing brain retractor pressure leads to a decrease in the regional cerebral blood flow. When the pressure of that retractor reached 30 millimeters of mercury, the injury risk was significant. When the pressure reached 40 millimeters of mercury, infarction was certain. This correlates with the known intravascular pressure of cerebral arterioles to be between 30 and 40 millimeters of mercury. It was shown that brief, intermittent retraction at 40 millimeters of mercury demonstrates less disruption to the blood-brain barrier than continuous retraction at 30 millimeters of mercury. Tissue hypoxia ultimately leads to cell death and can include apoptotic pathways via known inflammatory mediators. Detection of retraction injury. Monitoring regional cerebral blood flow can indicate a reduction of flow secondary to retractor injury. This can be done with intravascular fluorescence, intraoperative ultrasound, or intraparenchymal perfusion monitoring probes. Electrophysiologic neuromonitoring is another technique to detect neuronal injury, including retraction injury. This includes motor-evoked potentials, somatosensory-evoked potentials, or brainstem auditory-evoked responses. Finally, postoperative imaging, such as MRI or CT, can also show regions of infarction or microhemorrhage secondary to retraction. We'll now review some historical aspects of brain retraction. Prior to the 19th century, neurosurgical procedures typically did not enter the intradural space. Developments in anatomical research, antisepsis, anesthesia, as well as new instruments led to the modern neurosurgical age in the 19th century. Brune suggested saline injection around intraparenchymal lesions to facilitate tumor retraction and dissection. Balance described use of sponges as dissectors to expand and shift the brain. Early handheld retractors were limited by obscuring one's vision and insecure placement as they were not fixed. For example, Krauss described use of handheld retractors as seen on the left, a handheld instrument for retracting the frontal lobe, as well as vacuum suction tools to aid in intraparenchymal tumor removal. Lighted retractors were realized in the early 20th century. Fraser and Adson separately described intracranial lighted retractors, especially with regard to visualizing the trigeminal ganglion. Various original figures from their works are shown here. Next, various self-retaining retractors, which were soft tissue mounted, have been used in neurosurgery. The Bras wound dilator and similar retractors, as shown on the left, consisted of steel springs regulated by one screw. Wheatlander developed his eponymous self-retaining soft tissue mounted retractor, shown on the right, still in wide use today. For more robust deep brain retraction, skull-mounted retractors were introduced. De Martel, and separately Dot, developed a retractor system that was drilled and fixed to the skull during surgery. Amby developed a clamp, shown in the figure, that attached to the craniotomy edge, eliminating a need for drilling the retractor into place. Yasser-Gil developed the Layla retractor, a flexible, self-retaining retractor which was initially skull-mounted at the craniotomy edge. This was met with some problems, such as interference with the operator hands, tissue damage near the craniotomy clamp, shifting of the mounting device during use. The Layla was eventually modified to become mounted to the operating table, as shown in this figure, showing a skull and a Mayfield head holder with the two table-mounted Layla retractor blades in place. Mayfield and Keyes developed the Mayfield horseshoe headrest in 1967, followed shortly by the 3-pin skull clamp, still widely used today. Sagita released a related 4-pin head holder as well. These eliminated head movement and also served as attachment sites for modern self-retaining retractors. The Buddy Halo retractor system, developed in 1981 by Richard Buddy in Cincinnati, is a widely used headrest-mounted retractor that is designed to attach to the Mayfield skull clamp. Any required movement of the table, or the patient or their head, does not require retractor repositioning. Here are the components to the Buddy Halo retractor system in their official terms. The main halo ring A at right. Two flexible arms, which hold the retractor blades, are labeled B. The halo support brackets, which mount to the Mayfield, are labeled C. D shows the rods which support the halo ring. The adjustment wrench is E, and interchangeable retractor blades are shown at G. And a patty tray can also be used, as shown as F. This is a video depicting the proper assembly and disassembly of a Buddy Halo retractor set. In this scenario, a skull is placed in a Mayfield head holder, left side up, with the malar eminence parallel to the floor. To start, the support brackets are placed, one on each side of the Mayfield head holder. This is shown here from multiple angles. We typically place these brackets immediately after the surgical drapes are in place, before starting the operation. The bracket will mount on the outside of the drapes, with the thin drape between the bracket and the Mayfield. The bracket is hand-tightened to the Mayfield, and the slot which will hold the rod is positioned in line as the rod will sit, and hand-tightened. Next, the halo ring and support rods are brought into the field. The rods are placed into the brackets. The locking ring nuts are hand-tightened. Next, the locking ring nuts are tightened with the wrench tool. This is shown from multiple angles. The support rod has flexible ball joints, allowing the ring to be moved with respect to the rods, to allow precise positioning of the halo ring over the operative site. The halo ring and its built-in handrest segment are moved to the desired angle, and the halo hinge thumb screws are then tightened. Or, the ring can be folded back upon itself for greater exposure. The flexible arms are attached to the halo ring. The dovetail segment of the arm slides into the halo ring, and the bolt is tightened to lock the arm in position within the halo ring. This is shown again close up. Next, the malleable retractor blades are inserted into the arm via the chuck. The blades are moved into position, and the arm is tightened by turning the thumb screw. This is an example of the patty tray used on the flexible arm. Here is a patient undergoing a left pterionocradiotomy with the Buddy Halo retractor system set up with a retractor blade on the temporal and frontal lobe. To disassemble the Buddy Halo, remove the retractors from the brain. Then use the wrench tool to loosen the locking ring nuts at both brackets. The ring and halo are removed in one piece and set aside. A patient undergoing a left pterionocradiotomy with use of the Buddy Halo retractor. One retractor blade is shown under the frontal lobe. Tubular retractors give intraparenchymal access with limited and well-distributed parenchymal retraction. This is an example of the Vicor. Ultimately, brain retraction is minimized as much as possible. Proper positioning and surgical technique, supported by advanced surgical instruments, can allow retractorless surgery. Spetzler reported a consecutive series of 223 operations, 97% of which were completed without the use of retraction.